And I just want to reiterate, all of the images you showed up there, axial images, I didn't think some of the diagnoses were obvious on the axial images. Please, please get into the habit of looking at the coronal images. The spine things, I miss spine lesions all the time on the axial images. I mean, thank God I've got residents and fellows to read out with, and believe me, I'm sure I do some medical legal consulting as well. I never lose track of the fact that, you know, we have a privileged position in academics where we have a second pair of eyes on almost all the cases that we read. But so we are sympathetic to what you're facing, but you can make life a lot easier on yourself if you look at those sagittal and coronal reformations. They're really important.
Yeah, I think there was actually, I was going to write that article about 1980 something, but the guy in neuro was so nasty. I won't mention his name, we're recording, but so I didn't do it. There was an article published a few years ago that shows you miss about 80% of spinal fractures if you don't do sagittal views.
Well, and it isn't even just the spinal fractures. So my colleagues before I got to Stanford, Terry Desser and Shreyas Vasanawala were among the authors about how many lesions in abdominal imaging were missed in retrospect, multi-reader studies, by not looking at the axial or the sagittal and coronal images. It's a very substantial number.
We've been saying that. Some of us have been saying that for a long time. No, I think the thing is, you know, I was always disappointed way back when that even, you know, when you went from film to PACS, it really was the same thing, right? You know, so okay, it wasn't film, it was electronic, but it was still scrolling through slices. The main reason to be on PACS or anything electronic was the ability to look at coronals and sagittals. That was clear in 1987 with Pixar, because basically what we did with Pixar is it was the creation of the viewing box that would be a 3D at the bottom right, axial, coronal, sagittal. We should have patented it. We would have made a few bucks. But I think these days, I know it's a challenge. All of us, whether you're in academics or private practice, I think everyone needs to read more films, right? So there's this tremendous thing about RVUs, and so there's a tendency to try to go as fast as you can. I think what we do in our practice, and because the scanners allow it, and probably most of your scanners as well, we have the technologists have the program so that when they scan a patient, the coronals and sagittals are automatically generated, and then they're shipped to the PACS system. So you have it there, because if you have the radiologist having to do the coronals and sagittals themselves, they'll say, it looks normal, they won't do it. Once it's there, you kind of feel compelled to look at it. And not to mention the surgeons have been saying for 20 some odd years that if they only could have one thing, they would want the coronals. They don't want axials. Fergus?
Yeah, the two good housekeeping things I teach my residents to do, and I try and do myself on every single case, is look at the scout view and look at the sagittal. Because, and Elliot, you've told me this, that there's, you know, a pickup rate on the scout view of I don't know what percent, but
2%.
2%, yeah. So those are take-home messages. Look at the scout view and look at your sagittals.
Right. So any questions from the audience? Let's see. I can just ask Mike a question. In terms of, we commented on this before. So a patient right lower quadrant pain ER, what's your ideal protocol in terms of oral and IV contrast?
Yeah, so I get asked that question every time I speak, and so I'm happy to reiterate it. So we essentially never give positive oral contrast media to patients in the emergency department. It actually is not only an unnecessary delay, the issue that the ER docs come up with, but more importantly, many of the things I want to be able to diagnose out of the ED are not only, well, they're actually better diagnosed with no positive contrast in the gut. So if I want to diagnose bowel ischemia, if I want to see acute inflammatory processes, et cetera, if I want to see active bleeding, I'm going to see that better without positive contrast material. Conversely, so on like a Wednesday, I might be reading inpatient CT where none of the patients have positive contrast on board. Every Monday, I read at our cancer center, and almost all of the patients get positive contrast medium. Why? Because many of them are cachectic, and it still is a relative difficulty in recognizing unopacified bowel from lymph nodes and so forth. So, yeah, depending on which setting I'm in, it tends to be a binary all or none phenomenon as to whether we're giving oral contrast or not. We have some technologists in the audience. If your radiologists are still insisting on infusing contrast at 1 or 2 ml per second, please, you'll be a voice shouting in the wilderness, but there is no reason to give contrast that slowly. Everything shows up better when you give contrast as a sustained bolus. For some of the things we've talked about today, the GI bleeding, other things, you just absolutely, the active bleeding, and the patient that Fergus showed who had the post-prostatectomy, I think, and bled from the inferior epigastric artery, you're not going to see that unless you're giving a bolus of contrast sufficient to make the bleeding denser than anything in the abdomen. So you got to give contrast. I don't think we ever administer contrast slower than 3 ml per second, and we'll go up to 5 routinely. You can do it now, by the way, with small catheters. You can do it with a 20 gauge catheter with multiple side holes. So there's really almost no downside to doing it.
Right. You know, just to follow on that point, and the case that Fergus showed, the GI bleeding in the pelvis, I think it is true. If you see bleeding anywhere, it's when I spoke about you know, colon or small bowel bleeding, or Fergus showed the case of pelvis bleeding post prostatectomy. You do when you see really dense, and you know it's blood there, you got to look like a third time to make sure, because the bleeds aren't, you know, 4 centimeter enhancing things. Every once in a while they are. But I think especially with robotic surgery, it's very easy to nick a vessel, and it's often at the very edge. Like that case was right, the inferior epigastric arteries. I've seen this with hysterectomies, the same thing. They come back and it's some internal iliac branch or some gluteal branch. And the same thing is true with GI bleeding. You know, as I mentioned, you look at the bowel, and whether it's a stomach or a small bowel or a large bowel, it looks high density. You know it's bleeding, okay? And it's probably recent bleeding. Now, sometimes you're not going to see the bleed because it's stopped, but I think sometimes you just got to look more carefully, particularly if you only have a single phase and it's not optimal. It's very easy to walk by those bleeds, and they're going to kill you, because eventually, you know, the thing about legal cases, all of us have been involved in those cases one way or the other. You know, in retrospect, everything is obvious. You know, when you look at a case at the end, you know, it's like when you read a film sometimes and you look and you say, oh my God, what idiot missed it last time? Then you look, it was you, you know. Everyone missed that. You know, it's kind of like that. So it's like, someone told me when I started my residency, the only person who doesn't miss anything is the person who doesn't read anything. And I think that probably is true no matter how good the scanners get. I also think in terms of misses, I think you're more apt. So, you know, in the old days of scanning, a small mass was 4 centimeters, right? You know, realistically. And I think you miss more things now than you missed 20 years ago. And you can say that sounds really dumb, but I think it's really true, because it's not so much that you miss things as in miss and you're wrong about missing it, but it's missed opportunities, like small bowel tumors. You know, in the old days, you could not pick up a small bowel tumor. Or you remember the old days, which I don't know when the old days were, to be honest. I think that's when the Eagles first started. When you look at, like, for example, looking at neuroendocrine tumors of the pancreas, I remember the articles. CT was 30% accurate for neuroendocrine tumors, okay? So you collected a few, you had a few insulinomas in your lectures, but 30% accuracy. Now it's like 95, 98% accurate. The biggest problem with neuroendocrine tumors, we pick up a lot of incidental neuroendocrine tumors. No one ever picked up an incidental neuroendocrine tumor. Now you pick them up, and now the question is, how do you manage a 1 centimeter peanut? How do you manage a 2? Do you need to operate on everybody, or just leave them alone?
One of Fergus's case was the missed HCC, and I've seen a number of those cases. To put it in perspective, you know, I've been in the business since 1978. In the first decade of my career, I don't think I ever diagnosed a curable hepatocellular carcinoma. Never. They came in when they were symptomatic. We had a single phase of contrast administration that was about 2 ml per second. We had to do that because it took a minute or more to scan through the abdomen. We didn't recognize that HCCs were hypervascular and washed out. That was a sign that you couldn't possibly detect back in that era. But your protocols need to evolve to fit modern realities. We expect to diagnose HCC now when it's less than 2 centimeters in diameter. We just expect to do that. And those are curable HCCs. Another thing, when early in my career, if you said this patient with colon cancer has multiple liver metastases, that was a good enough diagnosis. If that was the impression of one of my dictations nowadays, I'd get a call from the referring oncologist or surgeon saying, what idiot dictated this case? What do you mean multiple metastases? What does that mean? Is it 2 in the lateral segment? I can cure that. Is it 6? What's the distribution, et cetera? So, our advances leapfrog the clinicians and vice versa. And so they, as they say, look, we can cure a few liver metastases, and they can from certain tumors like colon cancer. The demands on us go up, and we really need to adapt our technology and protocols to meet that. If you have multiple different models and eras of scanners and you're using the same protocol for each of them, some of them are definitely wrong, because you can't be using the same protocol for scanners that are scanning at different rates and so forth.
All right, good point. Questions, anybody? Okay, so let me ask one question. This is, now, we had LIRADS, BIRADS. Every week I read this seems like another RADS. Any thoughts about that? Because my concern is, I think all of us and many of you in the audience go to multidisciplinary conferences. So when I go to Pancreas every Tuesday at 11 o'clock and 4 o'clock, and it's really the best time to deal with your clinicians, and you kind of know what they want to know, and you kind of tailor your exam to that as well as your report to that, because you want to answer the questions they want to ask. And I think at times with all of these different things, we fill out a lot of forms, but we may not be answering the question they're answering. So, any thoughts about that?
Well, I'll start. I was on the LIRADS commission. Even so, I can't remember the graph, the table, I should say. So we have it posted at our workstations. More importantly, we actually have a template for how to dictate the cirrhosis, HCC surveillance CT scan. So if there's a mass, the spaces call for the person dictating the case to indicate the key findings. I've said all along, it actually isn't terribly important that you call it a LIRADS 1, 2, 3, or 4, or 5. It's important that you know what those imply, I believe. And again, I'm saying this as somebody who helped write those. I also believe it isn't important that you try to memorize the TPNN staging systems of all these different tumors, because they change all the time, and even the oncologist can't remember them. That does not absolve us of the importance of putting in our dictation the criteria that are important in the staging. So, if you're dictating a renal cell carcinoma case or a solid renal mass, they're going to expect, and I would expect, we're going to talk about the size of the mass, whether it breaks through the capsule or Gerota's fascia, whether there's renal vein invasion, local lymphadenopathy, distant metastases, and so forth. If you do that, then I think we have fulfilled our duty. Whether you remember which TNM stage that is, I feel is much less important.
Fergus, any thoughts?
I don't have a problem with LIRADS in and of itself, but I think people use it to hide behind giving me their impression as a radiologist and a physician, and the report will have 5 LIRADS observations and numbers and sizes, and it's like reading a telephone book. And I don't know, are you saying this patient has multifocal hepatocellular carcinoma or not? Yeah, and it's like saying 4.1 cm enhancing renal mass. Well, do you think it's a renal cell carcinoma or not? We're physicians, and we need to give a physician's impression, not just descriptive monkey speak, or we'll be out of a job.
I totally agree. And in fact, I've been doing liver transplant tumor conferences for the last 30 years now. And the transplant teams don't follow LIRADS. They follow the OPTN criteria. Now, fortunately, an OPTN 5 lesion is a LIRADS 5 lesion, meaning I am certain this is an HCC. So I'd also say the same thing. You talked about the Bosniak categorization. I loved Mork Bosniak. I think he made tremendous contributions. But I would never let a resident or fellow dictate paragraph impression, Bosniak 3 lesion in the kidney, because I don't know that the clinician knows what that means. So if you want to say Bosniak 3, that's fine, but I think you should put in parentheses or comma, complex cystic mass in the kidney with nodularity, comma, worrisome for a cystic neoplastic lesion, either multilocular cystic nephroma or renal cell carcinoma. And it's the same thing for the dozens of cirrhotic patients we see. When it comes to the impression, it may say LIRADS, parentheses, OPTN 5 lesion in the lateral segment, comma, definitely HCC, or it may say multiple other peripheral lesions of little concern, parentheses, LIRADS 2, comma, likely representing arterial portal shunts.
Yeah, and this, we're running out of time, but just to make one point, the reason this becomes important also is because, just by show of hands, at your hospital or your hospitals, wherever you are, does the patient have access to the chart, like my chart or the equivalent? So probably most of you, right? So now the patients are reading their chart. So usually when patients have problems, somehow I can get the one who they call up. So some lady called me up and she said, listen, the whole thing is screwed up at Hopkins, the whole thing. I said, well, I looked at the case and we read it correctly. It was a simple cyst, like a 4 cm cyst. She goes, well, the whole thing's screwed up. Last time I had a simple cyst in my kidney. Now I have a Bosniak 1 cyst. Okay, so now you're sitting there at 6:30 at night. You say, maybe I should go home. And then you say, well, okay, should I do 2 things I could say? One is, well, let me explain to you the Bosniak classification. No, I don't want to do that. And B, you could say, well, it's the same thing. Well, okay, which is what you kind of say. Well, Bosniak 1 is the same thing. You go, well, why didn't they say that? And I think one of the challenges now, and I do know that I'll just say Google is working on it, because the question is, how do you translate, since patients are reading their reports and they read them really carefully, they just want to know, do I have a tumor or not, or what's better or worse? How do you translate complicated reports into people speak? Because people are reading it, and some of it, sometimes we say things that really mean it's nothing there, and they read it, it sounds like, oh my God, I got a LIRADS 2 and a this thing, that. And so it's an interesting thing, because it becomes complicated when it's not only the information for the referring doc, who may not know what we mean, but the patients who are reading the charts, and it creates a lot of havoc. So I think we'll stop at that point, and when I speak tomorrow, I speak about AI, so I'll tell you how AI solves all these problems, or makes them worse, one or the other. Well, have a great evening. We'll see you again bright and early tomorrow morning. Breakfast is at 7:30. We start promptly at 8 o'clock. Have a great evening. Don't win too much money. If you don't leave the hotel, you can't win, you can't lose. So have a great day. No,